Hello, welcome to Pediatric Pulse. Today we will be discussing a critical and urgent topic in pediatric healthcare on life-threatening asthma. While many children manage with their asthma with proper treatment, some experience severe exacerbations that can be life-threatening. Life-threatening asthma in pediatrics refers to severe asthma attacks that do not respond to standard treatments and can lead to respiratory failure. Here are signs and symptoms of life-threatening asthma in pediatrics. The first one is the child will present confused, drowsy, and exhausted. This is due to hypoxia. The child is also unable to talk due to difficulty in breathing. There is also maximum accessory muscle use, and poor respiratory effort is a preterminal sign. There is also marked tachycardia, and sudden fall in heart rate is also a preterminal sign. The child will have a peak expiratory flow of less than 33% of best or predicted. The oxygen saturations will be below 92% in room air. On auscultation, the child will have a silent chest, cyanosis, and hypotension. For the management, ensure that you are doing continuous oxygen saturation monitoring. Also administer high flow oxygen via non-rebreather mask and titrate to achieve oxygen saturations between 94 to 98%. Refer the child to PICU or the pediatric ICU for escalation of care in case of impending respiratory failure and continuous monitoring. Administer beta-2 agonists via nebulization, for example, salbutamol at a dose of 2.5 to 5 milligrams every 20 minutes with the pratropium bromide at a dose of 250 micrograms for the first 2 hours. Also remember to reassess frequently and intervene accordingly. Remember to administer oral steroids, for example, prednisolone, at a dose of 20 milligrams for children between 2 to 5 years and 30 to 40 milligrams for children above 5 years. Remember, the steroids will reduce the airway inflammation. Repeat the dose of oral steroids if the child vomits, or consider intravenous steroids, for example, hydrocortisone, at a dose of 4 milligrams per kg every 4 hours. If still no response, give a bolus of intravenous magnesium at a dose of 25 to 75 milligrams per kg per dose as a single dose where the dose is expressed as magnesium sulfate. If still no response, consider early single dose 50 to 200 micrograms over 1 minute of IV salbutamol where the child has responded poorly to inhaled therapy followed by infusion of salbutamol at a dose of 1 to 5 micrograms per kg per minute. Consider the use of aminophylline if the child is unresponsive to maximum doses of bronchodilators and steroids. Also consider doing an arterial blood gas if poor response to early treatment for the plan of care. Thank you for watching. See you in the next video.